I'm John Chambers, and I'm in conversation with Guy Van Camp and Philippe Pibarot. And our discussion today is about discrepancies in assessing valve disease. So the first question I've got is for you, Philippe. Where do you think that these discrepancies that we find are particularly important clinically?
Well, first I think, John, that in the field of AS, aortic stenosis, one particularly challenging subset is the patient with low gradient AS. When there is a high gradient AS, I mean, it's a no-brainer. If the patient is symptomatic, there is a class 1 indication for valve replacement. Where it's really becoming challenging in these patients who have a small valve area consistent with severe AS, but a low gradient consistent with non-severe AS. So you have a discrepancy. In most of the case, this low gradient AS will be due to a low flow. That could occur with a preserved LV ejection fraction or low LV ejection fraction. The subset with preserved LV ejection fraction is more challenging and more controversial. The other situation where it's particularly challenging is when you have multivalvular disease. Because when you have, for example, MR with aortic stenosis, it's becoming very challenging because the presence of a mitral regurgitation may in fact result in a low gradient aortic stenosis. Also, when you have a concomitant aortic stenosis and aortic regurgitation, it becomes very challenging to assess the overall severity of the aortic valve disease. So to me, these are really the most challenging subset.
Okay. Well, Guy, perhaps I can ask you first of all about discrepant aortic stenosis. How do we resolve this common problem?
Well, it's difficult. It's a difficult job, and so it's very important to go systematically over the difficulties. You have to know the shortcomings of the technique, and centrally you have echo, but with echo you can make different measurements. And you can confrontate one measurement with another one. You can determine stroke volumes by different methods. Once that you have done that, and if you have still questions, you can go to the next stage, and then you can choose other techniques, and CT is having now a big place, looking to the calcium component in aortic stenosis, for example.
Okay, if I could ask you about the next problem, about multivalve disease, because again, this is increasingly common as our population ages. How do we resolve that?
Well, in multivalvular disease, it's extremely important to know the shortcomings and the caveats of echocardiography. When you have certain combinations of valvulopathies, sometimes one measurement, you cannot use it anymore. It's not a problem if you know it, of course, and if you take into account that. Now that can bring you in a situation where you don't have 3 or 4 numbers that can help you, but only one. That means that if you have other techniques that can help you to be more confident, you have to use them.
Okay. Can I ask both of you now, we increasingly are starting to use CT and CMR in cardiology. Do these techniques have anything to offer in these discrepant situations?
Yeah, well, first, before getting into that, John, I think we should optimize the utilization of echocardiography because this is the main modality that you're going to use. And I think the beauty of echo is that you can measure the same phenomenon by different ways. And I think you should have a comprehensive assessment and make sure that the numbers fit together. For example, if you have you measure the low flow in a patient with aortic stenosis, but you have a normal sized ventricle with a normal LV ejection fraction and you cannot find the explanation for the low flow, there is something wrong and you have to reassess. Now, having said that, if there is persistent discrepancy with echo, I think this is where you should look for other modalities. As Guy mentioned, I think the aortic valve calcium scoring by CT is a very useful tool that is, I think, ready for prime time in clinical practice, and it can be used as a method to corroborate the stenosis severity, as a safeguard, if you will, in this low gradient AS. And for CMR, maybe, Guy, if you...
Yes, I think it's a little bit parallel to aortic stenosis in mitral regurg, for example, where it's very important to know exactly what the function of the left ventricle is. If there is subclinical LV dysfunction, you have to detect it. If you are in doubt with your echo tool, just go to CMR. It's an excellent technique also to look for fibrosis. And also there, I think we are ready now to use it in clinical daily practice.
Okay, let me summarize that. So we've been discussing discrepancies which are most important in low flow aortic stenosis and in multivalve disease. And the most important thing is to use echocardiography to its utmost, to use all modalities within echocardiography, interpreted clinically, And then if doubt still remains, we have the option of CT and CMR looking at calcium, looking at evidence of LV fibrosis, and these will become increasingly important as we gain data in the future. Thank you. Thank you to you, Guy. Thank you to you, Philippe Pibarot.
Thank you.